everything just falls in line. We live and learn from our mistakes. The deepest cuts are in our faith. Now I believe there comes a time when everything just falls in line. We live and learn from our mistakes. The deepest cuts are in our faith. Now I believe there comes a time when everything just falls in line. We live and learn from our mistakes. The deepest cuts are healed by faith. Now I believe.
Welcome to ReneMarie Stroke of Luck. I'm ReneMarie, and this is gonna, we say this every week, and I have to give much gratitude to Judy for the intense work she is always doing to put together shows. It's really a lot of work to get a show, not only to find guests, but to just coordinate and organize and come up with a topic and to really pull things together. So thank you so much, Judy, for the work you've been doing for 8 years. This is our 8th annual telethon. So Judy's been doing this for 8 years. It's a blessing to have her.
It's a pleasure. Thank you.
Thank you, Judy. To work with Judy is just incredible. We have a lot going on in our foundation, a lot of evolving and a lot of exciting stuff. One of the things we're working on is a talent night on June 6th with Diane Bronberg from the Senior Center. I'm drawing a blank on the name of the organization, but I'll get it for you before the end of the show. She is such a driving force in knowledge and educating people. And we're having some more of her guests, her group on, and she invited us to be a part of her group. And it really is a blessing. It's almost like we're branching out from Long Island to my home state of New Jersey. And we're really touching the world. Don't forget, one of our missions was to have someone representing us and getting the awareness out in every state through our organization. So, we're really doing our work. Another thing that's going on in our organization is Jim. Jim, are you on the screen?
I am not.
Okay. Can you put everybody on the screen?
I can. Right now it's just you, Renee. But I'll put everyone on right now.
Yeah, put everyone on. So can they see everyone because it's delayed? Okay. So we want to unofficially, but officially, we haven't really made the official announcement. I kind of like said it a little bit on the on our press. But Jim now, who has been a driving force on the video side and the streaming side and all that kind of stuff, is now an official board member for ReneMarie's Language of Love. So we're so happy to welcome you, Jim.
I'm very proud to be a member.
Oh my God, we're so happy to have you. You've been an enormous help to us and support. And what we love about it is you did it without expectations, without anything, just the goodness of your heart to do it to us.
I actually enjoy it, Renee. Thank you.
You're very welcome. You're welcome. Another thing that we're working on is over a year ago, I sent a letter to the President of the United States. I'm not political. This has nothing to do with one side or the other, in the middle side or whatever. But the reason that I thought that we needed to send a letter to the president was because his son experienced a stroke. And we thought it was just something that he would understand. When it happens to you and it touches you, then you kind of have a different view on it. So we sent a letter to him, and actually he responded a year later. We're so happy. And he said, "Dear Miss Testa Adams, thank you for taking the time to share your thoughts with me. Hearing from passionate individuals like you inspires me every day." That was part of his letter back to me. And I know he didn't write it. I know the White House wrote it. But to get a letter back to start the communication is really
that's impressive.
We're humbled by it. We're humbled by it. And the reason that I sent a letter was because ReneMarie's Language of Love Foundation Incorporated organization is campaigning to be appointed as, I don't have small dreams, to be appointed as United States Stroke and Aphasia Ambassadors. We want to work with the United States government to be the stroke and aphasia ambassadors. That's our goal. That's our mission, because we want to be able to have our voices in where it makes the difference. When I went to Washington, D.C. with the American Stroke Association as an advocate, I saw the power of that seat to be able to be in there. So we're really humbled and really look forward to taking the next step. Catherine and Ginny and I, Judy's got enough on her plate, are working on a letter now to send to all the senators and congressmen in our states and around the country. So we're really pushing to do this, and we're so excited. So when we get that letter ready to release, we'll release it for everybody. But to today's show, I call this show Simply the Best, because Dr. Bekelis and Jason are really they're just incredible. And we call this simply the best because there's no words. Like, they're just simply the best. They just have the drive and the focus and care and compassion and empathy and just really to make a difference in the stroke world. And we're so humbled that they take the time. They've been on our show many, many times. And just that alone is a little, I said this on the telethon, that it's a little wink that we're doing what we need to do. We're going in the right direction. We're pushing, we're helping people be educated. We're so humbled to have them back today. Judy chose a topic called thrombectomy for today's show. She knows about it. I have never heard of that before, but that's pretty good because I keep learning so many new things on this show. I'm going to let Judy read the press that she had put out, and then we'll start the show. And I want to thank Jason and Dr. Bekelis for taking the time today, because we know how busy you both are.
Thank you.
You're very welcome. Go ahead, Judy.
It's an honor to welcome back Dr. Kimon Bekelis and Jason Wallen to our show. A real honor. We're going to be talking about the topic of thrombectomy. Thrombectomy is a minimally invasive procedure to remove a blood clot from a blood vessel in the brain. The neurointerventionist guides instruments into a very small incision in the groin or the wrist. The instruments are guided through the arteries to the clot. Then the clot is extracted using suction or a stent, restoring blood flow to the affected part of the brain. Dr. Kimon Bekelis, skilled in doing thrombectomy procedures on stroke patients, is Chairman Neurointerventional Services at Catholic Health Services of Long Island, Director, Stroke and Brain Aneurysm Center of Long Island, Co-Director, Neuro ICU at Good Samaritan Hospital Medical Center, Director, Population Health Research Institute of New York at CHSLI, Assistant Professor, the Dartmouth Institute for Health Policy and Clinical Practice and Fellowship, trained neurosurgeon with subspecialty training in minimally invasive endovascular neurosurgery, specializing in gamma knife radiosurgery and complex spine and brain operations. Jason Wallen, Good Samaritan Hospital Medical Center, is one of the most registered radiographic technologists in endovascular neurosurgery in the country. And he was one of the pillars of the Stroke and Brain Aneurysm Center of Long Island and participated in a lot of the decision-making during the inception of the program. Jason has additional training on advanced imaging and post-processing techniques for intracranial stent visualization. And now I welcome both Dr. Kimon Bekelis and Jason Wallen to our audience.
Thank you. Thank you, Judy.
You're
very much.
We're honored. We're just, you guys are just the best. So, let's start out with Dr. Bekelis. I had asked this in the green room, like, what are give us some of the procedures, like, leading up, like when someone comes in for stroke, I know you have to evaluate them, but then you have different options, like the clot busting drug or thrombectomy, like what are the different options that you have to evaluate and decide where to go with a stroke patient?
Thank you, Renee. As you know, stroke is a very time-sensitive disease. All the decisions are made within seconds or minutes, and we're being held accountable for our ability to respond within very short periods of time. And the first decision that we make when a stroke patient shows up in the hospital is whether they should receive the clot-busting medicine that you mentioned, the IV TPA, which is an IV medication that can break the clot up. It's extremely effective for smaller clots. When the clot gets too large, it's not that effective. Only a third of what we call large vessel occlusions can be opened with TPA. So, we're a little limited when it comes to the more severe strokes. But TPA is a very good drug. The challenges with it are that, you cannot really administer it past a certain time frame, which in certain cases is in between 3 to 4.5 hours from symptom onset. So right off the bat, people that wake up with a stroke or, were not seen when the stroke happened, are excluded. And so you end up really giving TPA to a minority of patients because of all the challenges of timing, but also the challenges of people having contraindications to TPA administration, such as history of bleeding or other prior surgery that prevents them from getting a clot busting medicine. Now, that was the only treatment available for a very, very long time. I would say for the majority of all of our lifetimes, but things kind of changed about 6-7 years ago when new studies came to light that demonstrated that we can use endovascular techniques, surgery, but minimally invasive surgery done through the groin or through the wrist with a needle hole. And we can navigate our catheters and wires all the way through the body into the brain and remove those blood clots mechanically. And as Judy said, that can be done with a stent that's retrievable, that acts as a fishnet to pull the clots out, or with a suction device that sucks the clot out and removes it from the body. So both the TPA and the thrombectomy are not mutually exclusive, but you can give them both to a patient. But your first assessment would be whether they would get TPA. You get a CAT scan to make sure there's no bleeding in the brain so that you can give the TPA. And regardless of your decision on TPA, if the patient has a serious enough stroke to make us concerned that the large blood vessel is occluded, then we proceed to more advanced imaging, which is a CAT scan with contrast and what we call CTA, CT perfusion. And that tells us, A, is there a large blockage in the brain? And B, is the brain still alive? Do the perfusion properties of the brain show us that the brain is viable for us to be able to go in and retrieve the clot to minimize the risk of bleeding, obviously. So these are the two major acute interventions when it comes to stroke. All the other interventions are preventative, but these two are the interventions we're using to really change the outcome of a stroke.
We had this doctor on one time. I believe she was a doctor, and I'm drawing a blank, and it was many, many years ago, and it was in Jim's studio. She spoke about that when you go through the groin.
Oh, I know who. I know.
Yeah. She was incredible.
The hospital in Mineola.
Yeah, but actually, she said was that there's something that you have to put behind it to not cause another stroke. Am I correct in my mind, Dr. Bekelis?
Yeah, that's a little different procedure. What she was referring to is likely carotid artery stenting.
Okay, you're right.
Which back then was probably the only endovascular treatment we had to prevent a stroke. So, if you build up plaque in your carotid artery to prevent a stroke, or if you've had a stroke and you want to prevent another one in a semi-elective fashion, you can either clean the carotid up with what we call carotid aneurysm, or go through the groin or the wrist and stretch the blockage open with a balloon and then lay a stent to keep it open. But you use what we call a distal protection device, like you're describing, to prevent the debris from our manipulation to go inside the brain. That procedure has also evolved today, several years later, in what we call transcarotid artery revascularization, or TCAR, that allows us to take advantage of the benefits of a stent, the minimally invasive nature of the stent, but at the same time, it gives us a lot more protection than the original stents for stroke prevention by reversing the blood flow while we're deploying the stent. And this is a fairly new procedure. Again, it's called TCAR. But these are on the preventative side. On the acute management side, it's TPA and mechanical thrombectomy.
Wow. You're talking above me. Just so you know, I get that there's two different procedures, but the terminology is just I can't process that stuff. but that's only me. The world can, I can't, I don't get that stuff. So, Jason, you work so closely with Dr. Bekelis. You know, I know you kind of learn when you're around something. Do you have any thoughts on this thrombectomy procedure, or have you had any people in your recovery group that have experienced that? Talk to us a little bit about that.
Sure. So I've been doing endovascular neurosurgery for close to 20 years now, and the advances, especially around the thrombectomy, have really excelled in the past 6 years, technology-wise. When I first started, we had very rudimentary suction catheters, and retrieval devices could potentially do more harm than good, given the nature of them. And now they really defined everything well and made such advances that the technology has come leaps and bounds from what we started with. And our support group, we are open to all patients who've had thrombectomies. What we've had one of our patients who looked, his name's Herb. He comes to support group regularly, and he has no problem telling his story. But just 2 weeks prior to coming to support group, we did a thrombectomy on him, and he looked like, for lack of a better word, hell when he was on the table. And he came walking into support group, and he's doing so well. Even to this day, he's a very great advocate for stroke awareness. And that's one of the reasons why he himself come to support group. We have a younger woman. She was in her early 50s when she had her stroke, Christine. And we did a thrombectomy on her, and she comes to support others. And we're open to every patient on Long Island and family member, and sometimes family members more. So it's real important to get the word out there.
That is true. Jason, let's touch a little bit, because we know with Dr. Bekelis is, his neurologist and his titles. He's got like 20 million titles that Judy has listed, and they're so impressive. No, they're so impressive. But we know as a team, everybody needs a team around them to be successful. And you have played an intricate part in Dr. Bekelis's, his programs, right? Am I correct in my mind thought? I think Judy said that when she was opening up. But let's talk a little bit about what your actual job is. The radiographic technologist, is that what it's titled?
Mm-hmm. Yes.
What is it actually? I know you guys both do many, many, many things aside from just your titles, but what is it that specific title is? What do you do when you go in with Dr. Bekelis?
So really breaking it down to the simplest terms, it's a X-ray tech, if you think about it. Is really the base cornerstone of that, of my my title. But then I went into specialty of interventional radiology, which is where we use live cameras, and then we do minimally invasive procedures. And then I went into the neuro side of it, and that's where I've been for, like I said, close to 20 years now. Wow. And that's what I found most interesting. So I actually scrub in next to Dr. Bekelis, and then we assist with all the catheters, wires, and devices, and the machine itself, and wow. Just try to make sure everything runs smoothly. Wow,
I can't even imagine Dr. Bekelis like going into a surgical room. To me, it blows my mind. That you have the mindset to be able to work on something that is so fragile and so advanced, and so the brain, it blows me away, because our hearts are important in keeping us alive, as well as the brain. The brain is almost our computer, right? Our computer in life that keeps us understanding and navigating and being able to know what to do. Talk to us a little bit about that team that goes in there, Dr. Bekelis, how important the team is to have an operation, because you got to lead the way, but your team around you, how many people do you have around you when you're doing a surgery like this?
So we have a lot of, we have a big team. As you said, this is not a job that can be done by one particular individual. The team is obviously the proceduralist, me, and then you have an assistant in the form of a nurse practitioner, a physician's assistant. Then you have a radiation technologist like Jason, all scrubbed in on the table, hands-on, taking care of the patient. Then you have two nurses, either circulating or documenting during the procedure. You have an anesthesiologist that's obviously taking care of the patient. Most of these patients are awake and they're getting twilight anesthesia. And you also frequently have a neurophysiologist, which is somebody who's monitoring the brain activity while somebody's under anesthesia. You cannot really tell if they how they're responding to what you're doing. So just conservatively, I would say that there's at least 7 people in the room during most procedures, sometimes even more. But it's not just the team that does the procedures, to be honest with you. There is a much larger team surrounding us that has to do with the immediate response team in the emergency room when a stroke patient comes in, to make sure that all these timeframes are met and our interventions are very timely. And then also the post-procedural team that receives the patient in the Neuro ICU, neuro step-down unit, and takes care of that patient and make sure that they make it home without any issues. Because if our procedure is successful, it is because the management after the procedure is generally stellar, and the patients are put on the right medications, the right preventative treatments to prevent another stroke from happening. So both these directions are important. So it's actually a much larger team than just the 7 people that are in the angio suite, and so I'm very grateful. We've at the Stroke and Brain Aneurysm Center of Long Island, we've handpicked the majority of these people, and we're talking in the realm of almost 100 people that are directly involved with the Stroke and Brain Aneurysm Center of Long Island, and then you have maybe 300 or 400 people that are indirectly involved, and obviously that requires a significant amount of advocacy from our end to get them engaged and get them to buy in the program, and so it's a process, certainly. And the Stroke and Brain Aneurysm Center of Long Island has been around now for almost 5 years, and looking at where we started and where we are today, I can tell you that none of it would have been possible without the tremendous work of these hundreds of people, and so it's actually a team sport, like you said. It's not one individual. Obviously, as the leader of the group, I have a little bit more responsibility, but certainly success is attributed to every single person.
Yeah.
I have a quick question. You say that, Dr. Bekelis, that you use twilight anesthesia. Is that because you want to talk to the patient and try to get a response?
Yes, and also it is because we want to do the procedure as quickly as possible, so we don't want to waste time on putting somebody to sleep, because the most important thing when it comes to stroke is how quickly can you open the blood vessel, how quickly can you give the brain perfusion or blood flow, and general anesthesia would generally delay us and drop the blood pressure, so it kind of creates a couple of barriers to a successful outcome. But if we need to do general anesthesia, then we do it. If the patient is moving a lot and they're a bit of a danger to themselves by moving around, then we would do general anesthesia. But we try to go as quickly as possible. And because we do this twilight anesthesia, people that come in with inability to move their arm or their leg, and we do the thrombectomy and the brain gets perfused post-procedurally immediately while they're on the table, because they're awake, all of a sudden you see them starting talking, phasia is gone, they started moving the side that wasn't moving before, they shake your hand with the side that wasn't moving. So it's really remarkable to see how somebody is on death's door and all of a sudden they're back to normal, and 2 days later they're back home like nothing happened. So obviously these procedures have revolutionized the care of stroke patients and have made us all very happy to be involved in this field. And we were involved, Jason and I were involved in this field in its infancy, where thrombectomy was the black sheep and people were not really believing in it. But certainly with the persistence of talented physicians and researchers, we were able to prove that thrombectomy is an extremely effective operation that can literally change somebody's life.
Wow, that's impressive. That you're just removing the clot, and to be able to go from not being able to move and then to it just very, I mean, it's impressive. So how long ago did it start, Dr. Bekelis? How long has thrombectomy been evolving?
So, thrombectomy has been evolving, I would say, in a period over 10 years, but has not been the standard of care for all this time. It was mainly an experimental intervention at the beginning. It was only performed in the setting of clinical trials, not in the general public. And so really became available to the general public in the last 5 to 6 years.
Wow.
And, it really changed what we do in stroke. If you can imagine, in the past, if you showed up with a big blood clot in the brain and TPA, you're out of the window for TPA. But even if you got TPA, only a third of those would open. Then you would have a devastating stroke for half your brain. That would swell over a period of a day or two. Most people would need surgery to remove the skull, put it in the freezer, leave the brain to expand to save their life, but not change their deficit. So they would still have a devastating deficit. But to save their life, you would need to take the bone off. And then after, several weeks or months in the hospital, and after multiple complications like pneumonia or DVT-PE, these folks would make it to a nursing home where, after several months or years, they would die from something else like a pneumonia or some sort of an infection. It was a horrible fate, and we had no tools to address it. And these days, that's not the case anymore. Especially if you go to a comprehensive stroke center, and there's really two types of stroke centers: a primary stroke center and a comprehensive stroke center. And a comprehensive stroke center, like the Stroke and Brain Aneurysm Center of Long Island, your chance of recovery is really high because the whole team is attuned to identifying the patients that are candidates for these interventions, treat them aggressively, and then offer the post-procedural care that would make these people get back to a normal life. So really remarkable advances in a period of 5 years, and it was almost overnight when the trials came out that demonstrated that mechanical thrombectomy can be the standard of care based on the outcomes we see. That changed everybody's lives pretty much overnight because people started doing the procedure. And I would say in the 5 years that we've been that we've started the Stroke and Brain Aneurysm Center of Long Island, we have treated hundreds of patients with large vessel occlusions. And I think at this point we're doing probably the most in Suffolk County for sure. And they have done most of them have done very well. But the most important thing to consider is that, had it not been for this stroke center and for this phenomenal team, all of these patients would not have had this this outcome. So we're very grateful for having the opportunity to provide that care.
Yeah, I have a question. I know you guys do it, but do hospitals across the United States, are they all aware of this? My thought process is, and then you can answer the question, is like somebody that's out in the country, in the country, like out where hospitals are 2 and 3 hours away and all that kind of stuff. And, they're watching this show and they learn about thrombectomy, and their family goes to the hospital with with their family member that just suffered a stroke, and they say, well, what about thrombectomy? Like, what is that an option here? Can any hospital do it without like, I mean, is it something that all neurologists or all people in your field know about and know how to use?
Well, you know, in the last 5 years, it's become commonplace to perform this procedure in comprehensive stroke centers. So, you know, not every hospital performs it, but certainly all hospitals are aware of it. Now, the challenge, the challenge is that if you go to a primary stroke center, you're most likely going to be, and you need a thrombectomy, you most likely will have to be transferred to a comprehensive stroke center, which is going to be a little bit of a time loss, and that can have an adverse impact on your outcome. So it's certainly, you know, it's certainly available, but to some extent, we need to also be educated about the comprehensive stroke centers offering those services in our territory, in our area, to be able to go there and receive that care. And now a lot of it is obviously driven by emergency medical services, or EMS, and rules apply to EMS locally. And so there's rules in Los Angeles that are not the same as rules in Suffolk County, and there's rules in Manhattan that are not the same as Suffolk County. So there's a lot of work done on the back end, and we do a lot of that with EMS to identify the best way to take a patient to the hospital. Generally speaking, this is not something that a patient should be asking for. You know, or a family member. The emergency medical services in every area are very much attuned to this, and you know, because it's one of those interventions that has such a profound impact on outcomes that it doesn't need 20 years to become the mainstay of what we do. It was immediate. The second we knew that it was effective, it started growing, and in the last 5 years, it's grown with leaps and bounds. And right now, it's one of the most effective interventions we do.
Wow.
So, doctor, if you call 911 and you say somebody in your family is having a stroke, can you say, I want to go to Good Samaritan Hospital? I want to go.
It depends. Obviously, if you're in Manhattan, they're not going to take you.
No, I'm talking about on Long Island.
Yeah,
if you're in Suffolk County, let's say.
If you're in Suffolk County, most of the times that's going to be done. Now, the challenges are that in Suffolk County, the rules are that the EMS has to take a patient to a primary stroke center first, the closest primary stroke center.
That's what I thought.
That's because the rules haven't caught up to these advances. And but obviously, if the patient is requesting adamantly to go somewhere else, they might respect that, but also they have to follow the rules that they're under. Now, there's either hyper-local rules that have to do with, you know, distances and common sense, right? If you have a primary stroke center that's 5-10 minutes from a comprehensive stroke center, it does, even if you are closer to the primary stroke center, it does make all the sense in the world to just drive the extra 5 minutes and go to the comprehensive stroke center. Now, if there's 7 comprehensive stroke centers from where you live to Good Sam, then probably a good idea to stop at the first one. But you know, we
want the best.
I know, but these are very fluid situations, and you know, it's every time, and they're emergencies, and so a lot of the decisions are made with a few seconds to spare. And so certainly, you know, the patients and the family wishes are taken into account, but you know, sometimes we also have to look into what makes sense medically.
That's a good lead in, Dr. Bekelis and Judy, for, you know, shifting a little bit. You know, I know people that follow us on the show know that, you know, I'm always talking about my granddaughter who suffers from seizures. She's been diagnosed as Dravet syndrome. And we're not going to get into exactly what that syndrome is, because there's so many different syndromes and so many different types of seizures and all that kind of stuff. But I will say that one of the experiences that my daughter had this last go around when my granddaughter suffered a seizure is, well, first of all, I'm going to backtrack a little bit. When she went to Boston University, they said to her, not to wait as soon as she suffers to have a seizure, you need to call 911, because this specific type of syndrome could have a short seizure or a long seizure. So really, it just varies all the time. But the reason I'm bringing this up is because my daughter is involved with, goes to a specific hospital and area, but because this was such an emergency, her lips were turning blue, they actually took her to the closest hospital, not the other hospital. And it just, I mean, it like Dr. Bekelis says, it's really the protocols that the ambulance have to what they need to do under their protocols. I told my daughter, like, she should really contact the ambulance when things are calm and discuss with them what they need, because the hospital that they brought her to was not a child's hospital, wasn't a children. They didn't know anything about children. They weren't specialized in that. So, you know, it wasn't their fault that they were, you know, they don't know how to handle primarily children. So I asked Dr. Bekelis before we began the show if we could just touch on, you know, seizures are neurological. And what's the difference between a seizure and a stroke? Could Dr. Bekelis, can you share that with us?
Absolutely. So, you know, a stroke is a cutoff of the blood flow of a large blood vessel or a smaller blood vessel of the brain going to the brain. So the brain is starving for oxygen, and the tissue eventually dies, resulting in a deficit, weakness, numbness, inability to speak, something like that. A seizure is a little bit more, it's a little bit different, and it's more of an electrical phenomenon where the electrical function of the brain is disturbed and irregular, kind of similar to short circuiting, and it can result in hyperactivity as opposed to tissue dying. This is hyperactive tissue that results in too much activity, not too little as the stroke, but too much. And that too much activity can be manifesting in the form of irregular movements of the body, jerking movements like a seizure, like we've all experienced them and seen them. And so they're very two distinct neurological presentations. And generally speaking, the majority of the time, seizures are not related to a blood vessel problem. Sometimes they are, but the majority of the times, seizures are a purely electrical problem of the brain.
So if you suffer from seizures, that doesn't necessarily mean that you could possibly have a stroke.
No. Generally speaking, no. You know, there's some very rare conditions where that can be the case, but I would say in the overwhelming majority of the cases, there would be no correlation between the two.
Wow. Thank you for answering that question. I thought that maybe it was important. Judy, if we could just schedule a show about seizures and stuff like that, just
Definitely.
to understand it a little bit more. It's just a new thing. My daughter, Samantha, she's a child life specialist at Hackensack University. And when my granddaughter started to experience seizures, my daughter kind of had a good philosophy on it in bringing it to us. And she said, you know, when I was young, I used to have asthma. She had bad asthma. She couldn't breathe all the time, and I had to put the nebulizer on. She had to put steroid. She goes, it's seizures is, you know, along that line in a different facet. You know, you have to look at it like this is a condition that you have to deal with, and we have to start learning about it. I could hear my daughter breathing incorrectly when I was sleeping and just wake up to that because I was so in tune with her condition. The same thing with my daughter. I always tell my daughter, you'll know your daughter better than anybody. Just trust in your instincts, and you just have to navigate through it. You just have to navigate through it. So, Jason, I want to give you the opportunity to, tell us what's going on in your world with the stroke recoveries and the people that hang out and come and all that kind of stuff, because that is an important thing. Life does happen after strokes. Life is important after strokes. It may be a new road that you have to go down, but you have to accept it and just be willing to go those new roads. So talk to us a little bit what's going on with your world with that.
Absolutely. And that's actually a great attitude that we try to promote at the Stroke and Brain Aneurysm Support Group. You know, a lot of times patients have to face their new reality, and with the hope of getting back to where they were. But like so many of our patients say that, you know, you have to take it for what it is right now and work toward that, but don't be stuck in a rut. A lot of our patients that come are there for support of each other. It's a great resource center. It's a great time to touch base with people that have been through what you're going through now. And we encourage family members with or without their loved ones. Sometimes their loved ones can't make it due to the fact that they might be in rehab, or they might have physical disabilities that don't let them leave the house right now that they want to. But the family members might need that support as well, and that resource well to kind of get into. So we definitely encourage that. We're open to all patients on Long Island, not just our patients, which is important because stroke has been here much longer than we have. As Dr. Bekelis said, we're just going on 5 years. You know, we were blessed to be able to treat hundreds of patients in those 5 years, but we had patients that had stroke or family members that come and their family members have had stroke, you know, 7, 8 years ago, and they're still having issues and they're still looking for resources. So we try to help everybody who can come, and it's open to stroke patients and brain aneurysm patients, because a lot of times neurological issues tend to be the same. So they look for the same resources, they have the same issues. So, you know, it's something that we really tried to touch base and help with. And it's really a great support system for patients. We meet the fourth Tuesday of every month at the hospital. When COVID was rampant early on, we were doing Zoom just to try to keep things going,
Right.
especially because people feel at risk. So I felt it was very important to try to keep up if people, you know, needed it, that support system, so that, you know, they can ask any questions and get the answers that they need. So we're going strong. We still see new members. You know, the important thing is some people think that, oh, I'm going to the support group and they need to come every month, and then they don't want to make that commitment. But that's not what it is. It's
Right.
If you come once and you feel like you don't need it, if you come once and then 3 months later you know you go through something or you feel like you need it, that's what we're there for. So, you know, we're there as much as you need us. So it doesn't have to be an every month thing, and I hope people realize that.
You know, it's so, you know, I always talk about this because I guess this is one of my like things that I'm really trying to help my stroke family is, you know, sometimes you don't understand what it is that you need, you know. Sometimes they don't understand, like they're lost. Your brain is combobulated, you know, and you don't understand that going to your center, your help is really important in getting out of the stroke world. It's really important to help you to evolve and to take that new road, you know, down. And do you guys focus on say anything to other than your great personality and your invitations? Do you reach out to the families as well? Am I correct in my
Yes.
patterns? Yeah.
All our patients at the hospital upon discharge, our flyers in there.
Okay.
You know, if we have treated a stroke with a thrombectomy, we try to stop by and talk to the family in person before they're discharged from the hospital, just to try to make sure that they know that we're there, and to kind of give them a little more information on what it's about. Like I said, they think that it's that commitment, and they kind of have to sign up for it, and there's no subscription fee, so we're good.
Right. So, you know, my thought patterns are like, if you would like me to come and have a show for you to sing, maybe it would be a different way to invite them to kind of see what the group is about without letting them know they're participating in the group. Does that make sense? Like,
Yeah.
like you invite them.
We had special guests right before the pandemic. Our group was one of the larger groups, support groups, even in the hospital system.
Yeah.
We were up to around 20 members every month. We had every month we had different guest speakers. We had a neuropsych doctor come one time and talk about antidepressants and all that kind of stuff, because depression is a big part of stroke. We had therapists come. We've had a music therapy come. We had all different. We were going to have dog therapy come with the dogs, and then the pandemic hit. Yeah, so then the pandemic hit. So then we were kind of very. We went to Zoom, and then when we were starting to come back, it almost every month is because the rules change. So we're not back to guest speakers yet, but I promise you, when we are, I think I'll reach out to you first, and you can kick off our back to guest speakers.
Yeah, I mean, I just think like to stay away my thought patterns. That's why I do. Let me backtrack a little. That's why I do the telethon, right? Mm-hmm. I remember Jerry Lewis. You bring entertainment, you bring people that joy, because we all understand that joy, whether we have a stroke or because we could feel the energy, we could feel the happiness, we could feel the joy, right? That never goes away. That feeling that you have. To invite them to feel that without, talking about your stroke, it's almost like, like, let's get into that group. That's why I always do the telethon. That was my thought patterns when I was watching Jerry Lewis. Wow, that's incredible entertainment. Oh, like everything else kind of follows suit. So that's why I always did everything with music in the forefront. That's music or entertainment, because I feel like, because I've learned when I've gone to perform for assisted livings and stuff, I'm like, I actually sing for 40 minutes without even talking to them, because I just want to get them into that wonderful, happy feeling mode. I want them to leave there like so high that they can't even, like they're flying, So I would love to come and help.
Absolutely. We would love to have you.
Yeah. Thank you so much. You guys are incredible. And thank you for your time today. We can't tell you enough. We know how valuable time is and how you have to pick and choose what it is you choose to invest in. And your investment into us is just a blessing, a true blessing. Judy, you have any comments on?
I only wish that there had been a support group when my dad had his hemorrhagic stroke. There was no support group. I tried to start one. I even had cards printed and said, let's all get together. And I spoke to people, but nobody wanted to talk about their husband or their wife or their child or their parents that had a stroke. So it was very hard to be alone. I had my support of my husband, but it was very difficult. So a support group is extremely important.
And I just speak from the stroke survivor side, that honestly, when I first had my stroke, I didn't realize that I needed the help. I didn't understand the correlation between my stroke and needing help. I just thought, oh, things are fine. I'm in a happy place, so that's why I'm such an advocate to help you in whatever way we can, because, we want everybody to kind of know that this would be such a great thing for them to have.
And same, I mean, that's our mission is really get in the community, get the word out for everything. And that's why we love supporting you, because that's what you're all about. So we kind of work hand in hand in conjunction to work in the right direction and just help people. So
thank you, Jason. We love you guys. Dr. Bekelis, we only have a few more minutes. I want to give you the last few words to really share. Talk about just to give us a clip about, the thrombectomy again, just how important it is that you guys have this now. This is really a wonderful tool in the tool belt to help those stroke survivors. Like you said before, just give us a little snippet of that.
Absolutely. Again, thank you guys for having us. It's always a pleasure to help you spread your message. As you're saying, thrombectomy is now the cornerstone of stroke care, mainly because it takes an extremely debilitating disease, the most severe, devastating strokes that result in somebody being in a nursing home or dead, and changes their outcome into a life without disability. It's really a night and day type of scenario, and it's very important to be performed when it's indicated. And so, the biggest message is to be aware that there's things to do for stroke. Time frame is important, meaning the sooner you get treatment, the better it will be. Like we say, time is brain. Now, thrombectomies we perform all the way out to 24 hours after the onset of symptoms, if the perfusion is demonstrating that the brain is alive. Therefore, the window for it is maybe larger, but it also depends on the individual patient and if their brain is alive or not. But certainly, multiple studies have expanded our ability to treat these patients. And so I would say, if you or your loved one is experiencing stroke-like symptoms, and I think we've spoken in the past in your show about FAST, which is face, arm, speech, time to call 911. If any of the above is affected, you see it in yourself, you see it in a loved one or a bystander, call 911 as quickly as possible. It will change their life, either through TPA administration, the clot busting medicine, or through mechanical thrombectomy. We're grateful that we're able to offer these services and to be at the forefront of stroke care on Long Island and the United States. Again, we're supporting your mission, and we're very grateful for including us in your show today.
Oh my God, we're blessed. I will say, I will comment on Dr. Bekelis. I will, add a little bit is we always know that when you call 911 and you feel that somebody is having a stroke, to please let the ambulance, the person at the 911 call receiving, know that it could be a stroke, because they go right into stroke mode. They just, that's I know the ambulance, they have protocols they have to do when they get there, but just that advance notice is really will save lives. And the other thing is, this is why we do this show, is to educate people. Yes, you may not have a history of stroke in your family. You may not have, you may never heard of a stroke. There are so many different types of strokes or different severities of strokes. People have mini strokes, so winged from God, that I call them. But it's so important to educate yourself on how to stay healthy and what to do in all scenarios, and just add this to your tool belt so that you could save lives. Our lives are so important, so valuable, and so short on time. We're only here for a split second in the universe, and it's just, it's a gift to be able to still be alive. I feel that way because my life was one split second. My life was changed. And I'm really gifted to be able to speak to you clearly and to be able to communicate with you. But those that are unable to do that, and possibly those that are unable to do that with the new advanced technology, just would be very sad if we had the opportunity to help them along the way. So we're so gifted. Judy, do you want to say anything before we rock and roll?
I just want to thank Dr. Bekelis and Jason once again. We really appreciate
Thank you, guys.
the time you spend with us and how you educate the public. And everything that you do is superb.
Yes, and Dr. Bekelis, I don't know if we said this at the beginning, but he won the award. Jason, what award did Dr. Bekelis win? And he wins. He's our winner, our award winner. But you could share what it specifically.
Best of Long Island in the neuro category.
Woo! Now we're going for the United States. We'll go for the United States. He's the best. And before we go, Diane Braunberg, who is working on the talent night with me, is her organization is called Senior Resource Group of New Jersey. And she's right in alignment with all of us, really education, really awareness. She is wonderful. And we're so blessed to be able to start this journey with them in New Jersey. I really want a heartfelt thank you to Dr. Bekelis and Jason, and you, Judy, of course, and Jim in the back studio. And we can't tell you how grateful we are for all your time. So have a wonderful day. Have a stroke of luck in your life. And we have another show with Patty coming up next, and we can't wait to see you then. Have a wonderful day. Let's blow our kisses. 1, 2, 3. Bye, everybody.
God bless you all.
Yo no sé qué tú piensas, yo no sé lo que haré, yo no sé lo que estoy perdiendo, yo no sé lo que va a pasar. No me puedes escuchar llorar solo sin ti, no me puedes oír llorar. Dime que caminaste por la puerta, todas las memorias fueron. Mi corazón estaba vacío, como si tuviera ayer. No me puedes escuchar llorar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír llorar. Usted está en mi sueño por la noche. Por favor, no veremos. Es tan difícil para mí y para ti. ¿Qué puedo hacer? No me puedes escuchar llorar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír llorar. No me puedes escuchar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír